And the final part of this discussion is patient selection, and that I leave to Professor Ejaz Lateef.
So, when we talk about in my opinion, every patient who is having a good visual potential and he is affording as well, he should be given the choice to have this multifocal IOL. But at the same time, I will also emphasize that we should not overexcite the persons. Because we should not increase his expectation too high, and otherwise he may be having some, maybe demobilized slightly if he has to wear some glasses. So we usually tell them that in 90% of the situations, you will not be able to, you will not require anything. Previous. But in 10% of the situations in life, you may need these glasses. And also we should avoid highly demanding patients. And if still the patient who is highly demanding and looks fussy, he is insisting for the IOL, multifocal IOL, we should have a written consent for any mild post-operative infection. The best patients, in my experience, the best patients are the housewives, teachers, and sedentary persons and the office workers. And the worst patients are frequently the frequent night drivers. Mostly they are frequent night drivers who have to drive in routine during night. So it's better to avoid these cases. And this is the most important question which we are asking to the patient, whether they have to drive in night regularly or during night time or not. And if they are regular nighttime driver, we don't offer usually, and we ask them to have monofocal IOL so that they don't have glares. And in the IOL sections, while doing the IOL section, we have to make sure that both eyes have the same mechanism of multifocality. Suppose if he is having this defective lens in one eye, the other eye should also have the same defective lens. Or if you give ADOF in the other, and there may be some difficulty in neuroadaptation because the mechanism is different in different eyes. So the patient may be feeling difficulties in neuroadaptation, and I've seen that patients are not satisfied when they are having different type of mechanism of multifocality in two eyes. And one important thing is that the monofocal, if the patient is having monofocal lens in one eye and he wants multifocal lens in the other eye, most of the persons or the eye specialists, they try to avoid that you have got a monofocal IOL in the previous eye and you should not have multifocal. But I have done this experience, and now I'm doing it regularly, that with this ADOF technology, I don't feel any problem. Patients are very happy. Those patients who have got monofocal IOL in one eye, they can have very easily, they can have multifocal IOL like of extended depth of focus, and they are very happy. Personally, I know many of them, they are young people and they are having one in monofocal and the other multifocal IOL, and they are very happy. So you can offer the patients who has already got one monofocal IOL, you can offer multifocal IOL in the second eye. If the ends better, we should have the EDOF technology and not the refractive. During surgery, I would like to say some special things which are to be done. And the one thing is the rexes. The rexes should be smaller. If the lens size is 6.5, it should not be more than 5.5. And it should overhang the margins of the lens all around so that it will keep the IOL centered, and it will also prevent TCO So it will something better. And the IOL centration during surgery we must make it central. But while making the IOL center, we should also avoid to touch the instruments like dialer to the central part, especially of the optic, especially the central zone or the rings. The instrument should not be touched to that, otherwise there may be problem of layer and layers. And I would also like to finish the second part of my presentation now, because it's only few slides about the post-op counseling of the unhappy patient. There are some patients which are unhappy post-operatively. The VN does not come to their expectation. So we have to mention them about the neuroadaptation. We should counsel them, and we should tell them that it will take few weeks, maybe 6 weeks to 6 months even, for neuroadaptation, because it's a new mechanism of seeing, and your brain will soon adopt it. And if we can also tell them that the best VN you will enjoy will be when you have the VN in the second eye, same VN or same mechanism of the VN in the other eye. So it's better to have multifocal IOL in the second eye, and the bilateral multifocal eye are much happier than unilateral because of the depth of the focus, and because both eyes, when you can open both eyes, if there is mild post-op refraction, this will be covered. And if the patient is still hypermetropic, or say he's having post-operative Part-5 and he's not happy with the near vision, he's okay with the far vision, then we should make the second eye slightly myopic, maybe 0.5 diopter myopia, post-operative myopia will work, and when he will open both eyes after the surgery, he will be happy. Mostly they are very happy patient after the surgery. So one thing which I want to mention is the comparison of the results. In the last 2 years, we have done almost 500 multifocal IOLs, and out of them, this ratio is 300 to 200 with the EDOF lenses, or 200, and the more are diffractive lenses are more. So, but dysphotopsia is more in refractive lenses. It's at least 35% patient are complaining, but with the EDOF or lucidus, only 15% are having dysphotopsia. And for the near vision satisfaction, diffractive are more satisfied by the way. It's about 90% are happy, and with the lucidus, 85% are happy. And overall satisfaction of the patient with the far and distant near vision, and the quality of the vision is better in the EDOF or lucidus, especially the because it's aspheric lucidus EDOF, and 90% of the patients are very happy. And there are many young patients who are driving regularly, and they are very happy with the outcome with the EDOF, and we are using only the lucidus EDOF. Now this is what we used to see very commonly when we entered in the field of ophthalmology about 30 years ago. This is what we used to see all around in third world, because the aphakic patients, and they were wearing plus 10 glasses, and they were very happy when they used to go back their home after camp surgery, and with 10 plus 10 glasses they used to see their cattle grazing in the field. So they were very happy. But now the things have changed. Now the patient want to see each and everything, from a leaf of a star to the clouds in the sky, everything clearly without any glasses. So we have got the multifocal, but for this, as the VL quality has raised from 6x Buffalo to 6x6 and N6 next day. The patient wants 6x6 and N6 next day without any glass. So, but in the meantime, we have got the multifocality, but in the meantime, we have left the asphericity. But here, with this new invention of ADOF technology, we are using this lens and we are providing both asphericity and multifocality. And with this technology, the patient can see very clearly, have crystal clear vision from near to far, with all contrast and natural colors, with the help of this ADOF technology. It is technology which is called the instant focus technology. Thank you so much.